Hello and welcome. My name is Donna Cryer. I am the CEO and founder of the Global Liver Institute, and I have the great privilege of bringing to you International NASH Day and this particularly special panel on NASH in lean individuals. NASH affects over 115 million people, and yet the seriousness and the urgency of this disease has not yet been recognized. That's what we intend to do here today. There is a common misperception amongst those who know anything about NASH that it can only happen in people with excess weight or obesity. That is not true. So today we will deconstruct myths and misperceptions on NASH and NASH in lean individuals. And I could not be more excited about our internationally renowned panel today. But before that, I just wanted to thank everyone for their participation throughout the full day of International NASH Day this year across all of our panels, videos, and activities. Please use the NASH Day hashtag on social media as we celebrate NASH around the world. I'd also like to thank all of our medical societies around the world who have come together to support International NASH Day. We could not be more honored that we have received the endorsement of AASLD, the American Association for the Study of Liver Diseases, and EASL, our European Association for the Study of the Liver, the home of hepatology. And in total, 15 medical societies, as well as the World Health Organization. Thank you so much to all of you. And now, without further ado, I'll bring you our august panel for today's conversation on NASH in lean individuals. Dr. Arun Sanyal certainly is no stranger to anyone in NASH. He is a professor of medicine, physiology, and molecular pathology and gastroenterology at VCU Medical Center. He also holds the role of chairman, NIH NASH Clinical Research Network, the NIMBLE Consortium, and chairman of the Liver Forum for NASH and Fibrosis. Dr. Abhijit Chowdhury is a clinical professor and chair of liver diseases. He's a board member of the Indian National Association for the Study of the Liver, and he comes to us from Kolkata, West Bengal, India. Dr. Mohammed Eslam is an associate professor of hepatology, and he is also head of the International Liver Disease Genetic Consortium. He comes to us from Sydney, Australia. We have Dr. Alnor Ramji, who is a clinical associate professor of medicine, gastroenterology, and hepatology, and the steering committee of CAN-NASH in Vancouver, Canada. And finally, we have Vincent Wang, who is chairman of the Eastern Regional Organization for Public Administration. It is a group that is United Nations pan-affiliated. He is also a visiting researcher at the University of Oxford, and he comes to us today from the University of Hong Kong in Hong Kong, China. Thank you, gentlemen, for joining us today. So I will start with you, Dr. Sanyal, in telling us about what has impacted NASH the most in the past 12 months. Certainly, COVID is top of mind for us all. And so if you just talk to us about the impact of COVID for patients with liver disease and particularly people with NASH.
Yeah, hi. Thanks, Donna. I think it's very hard to talk about anything that has happened in the last year, anywhere in the world, without talking about COVID. And we've seen the situation change in the West and then in Asia, and different things have happened at different points in time. So this has touched all our lives. One thing that has emerged in the last 1 year is the really important predisposition towards severe disease in people who have underlying chronic liver disease. And amongst the larger umbrella of people with different types of chronic liver disease, NASH and alcohol-induced liver disease really rise to the top. And there was a paper published last year looking at 62 million case records. That's a lot of patients. And what they found was that having underlying non-alcoholic fatty liver disease actually increased the likelihood of having severe COVID 13-fold. The odds ratio was 13. Similar data have been published from the UK Biobank, and there are also studies from individual universities confirming that. So now there's a body of literature suggesting that if you do have fatty liver disease, it may not necessarily affect your risk of getting COVID, but if you do get COVID, your likelihood of having severe COVID is increased. And this almost certainly is related to the degree of inflammation and the predisposition towards inflammation that is generated from the liver when your liver is already inflamed in NASH. So what we've also learned is that diabetes, obesity, these are all other common, more easily recognized risk factors for severe COVID. So the question then arises, how much of this is being driven by the underlying obesity and insulin resistance, which is associated with inflammation throughout the body? And do people who are lean sort of have the same predisposition? Now, in the West, the proportion of people who are lean and have fatty liver disease is relatively much smaller than in many other parts of the world. So certainly it seems that if you have fat in the liver, that is a predisposition. But I think it'd be important to hear from our panel about what the perspectives from different parts of the world actually are. So maybe we can ask Abhijit to go first, and then Dr. Islam can share his experience from Australia and bring it all the way back through the Far East back to Canada.
I would love that. Thank you. Dr. Chowdhury?
Yeah, thank you. Thank you, Donna and Professor Sanyal. Interestingly, as we walk past the COVID cloud, as I'm sitting in Kolkata, and we are really reeling under COVID. As of now, we are still on the upswing or stabilizing variety. So what I can see is, interestingly, many people, because of COVID and lockdown, many people who were lean earlier have now become obese because they had been sitting idle at home. So, what it tells me, on the other hand, is that leanness, as we define, is a very dynamic phenomena, and it's related. And often we make some variety of white and black scenario, but we need to keep in mind that NASH, NAFLD in lean individuals, those people whom we are seeing as lean today, can very well accumulate fat visibly as we consider as obese and become NASH in obese individuals, meaning that NASH remains the same. The individual apparently looks like lean to us, and we fail to measure or see the fat that is burning and is inflamed at some site, because we have fixed leanness. We have devised a way of looking at leanness which probably is imprecise and indiscreet in measuring the fat and related and metabolic health that we are talking of today. So what I want to mean is, when we talked of some years back, when we talked of NASH in lean individuals, it was thought of as an exotic entity. But let me tell you, as in after say 10 years or so, today NASH in lean individuals is in the center stage. And we need to consider that NASH in lean individuals is not biologically different from NASH in non-lean individuals. Unless we consider that, we are really probably not going to do the right thing. So, to me, it's fat in disguise somewhere. I'm not looking at that ectopic fat and not picking up that fat. So we need to figure out where the extra fat or aberrant site where the fat is lying, and that's all about NASH in lean individuals. So it's not right to think that NASH in lean individuals is a different variety of NASH as NASH seen in obese individuals.
So, Abhijit, can I ask, so something that patients may be asking is, well, I am lean, my arms are skinny, my legs are skinny. Where is all this fat? And so what we've seem to have learned is that particularly in males, and, you hide the fat inside your belly. So can you or Dr. Islam talk to visceral adiposity and the importance of fat inside the belly?
Okay. So yeah. Thanks, Donna, and thanks, Professor Sanyal. So exactly as you said, one of the issues with the current definition of lean fatty liver disease that it relies solely on the body mass index, which we know that it's imperfect index of the distribution of the fat. It can miss the body fatness in nearly half of the patient. And we know, as you exactly said, that the visceral adiposity might be more perfect and correlated with the risk of the development of fatty liver disease and the progression of fatty liver disease. So apparently the abnormal metabolic health might be, regardless of the body mass index, might be more indicative of the development of fatty liver disease. And we know now that nearly 1/3 of all lean individuals actually have a poor metabolic health. So the amount of the distribution of the fat, and we need more indications that can be more accurate than the current estimation, which is only based on body mass index.
So what is the better marker? Is it waist circumference, or is it percentage of lean body mass?
It's challenging because NAFLD is already recognized as a hidden disease. People don't even know that it exists half the time, right? I mean, that's the whole context of trying to have advocacy, international Liver Day, etc., is because so many people don't know about NAFLD. And then we are putting on top of that lean NAFLD, and I think the waist circumference is exactly it. That you're really honest. It's really those persons with a low BMI, or not a normal low BMI, but normal BMI. When you go to the lean NAFLD, what is a better marker? How are we actually going to find these patients? And the context of the waist circumference becomes important to indicate visceral fat. In Canada, we have a very multinational, multi-ethnic population. And I think that's one of the most fascinating parts about lean NAFLD, is that you see different prevalences around the world. And then you got to amalgamate that into a very distinct strategy. And it's simply is one size doesn't fit all, excusing any puns along the way. We have a heterogeneous disease, we have heterogeneous population, and that's the beauty of this. And then you've got newcomers in different places, and you really have to be very culturally sensitive, as well as sensitive in the context of stigmas, right? When you're looking at fatty liver disease, it's always been a stigma of obesity. And now you're looking at lean, and maybe it actually helps in some ways because it makes it less stigmatizing as well. But I think it's the waist circumference that we really should be focusing on in this.
And I think the beauty of using waist circumference is that is very scalable. All you need is a tape measure, and so you can take that anywhere in the world without having expensive, fancy equipment. And so it's sort of the ultimate non-invasive diagnostic. If you want to consider it that way, as we reach out to millions of people to start to understand their risks for NASH and whether they should be trying to seek care for that issue. Sanyal, what are the other opportunities in NASH? There's a lot of research, a lot of activity both on the diagnostic side and the drug development side. What can we look forward to seeing developed for NASH?
Well, I think in terms of diagnostics, it's really important to think about what it is we want to know when we see the patient. So the immediate thing we want to know is whether what is their risk of actually getting into trouble from their fatty liver disease, as we follow the patient over time. And so risk stratification and prognosis, understanding the prognosis of the patient is really important, because yes, about 20% of the population has excess fat in the liver, but actually 20% of people will not have a liver outcome. They will not die of liver disease, only a minority. So the big challenge, both for physicians as well from a patient perspective, is to understand, who is at risk of actually developing progressive liver disease. For the rest, there is increased cardiovascular risk, there's increased cancer risk, and those have to be addressed anyways. But a critical part of the liver story is understanding who is at risk. And, there's a lot of work going on using non-invasive tests. And much of the literature, of course, unfortunately, is not scientifically very robust. And there are two big initiatives, one in Europe and one in North America, called Litmus and NIMBLE, that are ongoing to sort of generate the kind of data and evidence, hopefully within the next couple of years, that will allow us to say, yes, we've generated the kind of data that meet regulatory standards and for qualification. Because unless something is qualified, at least in the West, it is unlikely that third-party payers will pick up and start routinely reimbursing that as part of a care pathway. So what to do in the meantime? Some of the simple tools, and I would love to hear from the rest what they use in their practice. One is, of course, a very simple laboratory aid called a FIB4, which was originally developed as a non-invasive surrogate marker for the amount of scar tissue in liver in viral hepatitis, but now has been validated in liver disease, in NASH as well, as a marker of scarring. But really, is more data is coming out linking it to outcomes. So that's one thing that I personally use. And certainly, people who have a FIB4 level less than 1.3 have a very low probability of having significant fibrosis or liver outcome within a 5-year time frame. So I use it right in the clinic. It's my go-to for the first thing I use. And then we follow it up with a fibroscan. This is, of course, based on what is available and what's within the realm of cost for most patients. The Cadillac is MR-based assessment, but at least I use it minimally simply because of cost reasons. And the incremental bang for the buck for me is not there as we move from fibroscan to MRI to do it in every patient. But I'd love to hear from the others as to what they use in their practice for risk assessment, particularly in lean patients versus obese patients.
Dr. Islam, what do you use in your practice?
So, yeah, we also use the same like FIB4 and NAFLD fibrosis score. But I guess with the point here, I would like to emphasize that we have some evidence that the performance of these scores in such a heterogeneous disease like fatty liver disease might be variable between different groups, and we might need a bit of modification. Like, for example, we have data that it might be variable into the young age from the old age, from different ethnic population. And we need to know that if the performance of these scores are equally good in lean patient or not. I think we don't have this enough amount of data at the moment, and it might be a point for research for the next year. But for the time being, we also use these scores for lean patient as well as for obese.
So Donna, one thing I would like to interject here is that, I think as a medical community, we've been asking the wrong question, and we continue to ask the wrong question, where we're trying to correlate all of these with fibrosis. Yet fibrosis itself is a surrogate marker and an imprecise surrogate marker of clinical outcome. What matters to a patient is whether they're going to live or die, whether they're going to end up in the hospital, whether they're going to need a transplant. Those are the kind of things, at least my patients tell me, is what matters to them. The esoteric aspects of their fibrosis stage really don't resonate so much.
No patient has ever been excited about histology.
Exactly. So we should be relating these NITs and these approaches to clinical outcomes rather than fibrosis stage. And I think that should be an important part of where the field should move forward to.
Certainly our work, and some of this we've done together, Dr. Sanyal, on patient outcomes measures is so important. I was writing in pain the day, and I think it's so important to come involved and talk about what matters to us, the risks and benefits, trade-offs that we're willing to make in NASH. And so I welcome that partnership. You know, what I'd love to be able to take a step back, since there are a lot of patients who will be in this audience watching this, is to be really specific about the numbers, because some people may not know what normal ranges of BMI are, and then, you know, these different types of tests. And so would someone like to, you know, just maybe go back, Dr. Elnor, and talk about, you know, just what normal BMI is, what overweight typically is, what it means in NASH, and how it differs in NASH and lean individuals, so that we understand that distinction. And then I'd love to explore this point about how the diagnostics may differ.
Vincent, are you on? Can you hear us now?
Last but better. Thank you very much.
Okay. Why don't you take this?
Yes, exactly. Thank you. Go ahead.
But just like, okay, just like I missed the question. The question is about the number of the BMI or whatever.
Yeah, just explaining in, you know, the simplest terms what, you know, normal BMI, overweight is, and how that's different for NASH when we're looking at lean individuals and the manifestations of.
Okay. So I'm not sure whether I fully hear you well, but I think I can share from the perspective of public administrators. So I saw the question here. Yeah, is normal BMI was overweight, and how is that different for patients with lean NASH? I think having been years of training for public health officials, I think this type of information is very vital, incorporated into the public policy school training. That would be highly beneficial, because I think I'm unlike the medical doctors, the gurus here. You are expert in the medical field, but whereas my expertise will be on the training of the economic policies or health government officials in funding. If the public health training institutes can incorporate 1 to 2 modules on, for example, for the key diseases of the current situations, they can have a sort of the training in the relationship between the public expenses as well as preventive measures in the funding. You know, as long as they get this type of information, I think they would do much better. Number one, in granting relevant, you know, funding from the health ministry to patient organization to hospitals, as well as they will invest more in the research funding. Because I think, from my perspective, you know, doctors are definitely great, but policymakers can serve better to the society, to NASH. Yeah.
So the Global Liver Institute has created a NASH action plan, to your point, with collaboration from the 70 different members of our NASH Council. In each of your countries, are there similar efforts, or is there an opportunity to work together to create a NASH action plan at the government level in you know, in Australia and in Canada, in India? Is that an opportunity for us to come together and work to create you know, a government level plan to address?
So Donna, I think we should ask Abhijit to start this off, because, you know, he had a paper in Science talking about a cohort he has created in rural India, working with the government on one side and with other international partners on the other, to really establish sort of almost like a model system in a very resource constrained place as to how to really manage NASH and have outcomes that are comparable to what we have elsewhere in the world with far more resources spent. So Abhijit.
Yes.
Yeah, thank you.
No pressure.
Yeah, no, sure. So interestingly, you know, India remains one of those countries where we are passing through tremendous amount of transition in every aspect: social, economic, lifestyle, as we think are relevant in the context of NASH. So, and India is vastly rural, so 80% rural, and so we thought that getting the picture of rural India and trying to devise how to tackle NASH in rural India could be a way for the vast parts of the world where you don't have advanced technologies available, advanced trained healthcare resources are available. So what we did is we tried to develop a system named Development of Metabolic Health Board, where we told that, we often look at NASH from a very reductionist. Me as a hepatologist look at NASH as a hepatological disease. Somebody who's a diabetologist look at NASH from a complication of diabetes. We need to understand that it's complete metabolic health, holistic metabolic health that is more important, and we need to get to this thought into the medical community, healthcare giving community. So we devised a group of healthcare workers who were given a tape to measure the waist circumference, a weighing machine, and a glucometer. And they were trained how to impart the understanding of metabolic health to the villagers. And so that was impact assessed also. We found, and these are the so-called informal healthcare workers who are there in the villages for long. In India, if you go, they are the first point contact in 80% of the circumstances. And so we try to impact assess whether imparting this training to them would improve their way of imparting understanding of metabolic health to these people. And interestingly, some very interesting observation we could see that this variety of approach could really impart understanding of metabolic health, their tendency to improve the villagers would look at diet as one of the important modifying factors for development of fat in the liver. But because I just want to share here that in India, and I think in large part of Asia, plumpness and obesity is equated with healthiness. Right. I see many people who come to my office, and when I say, hey, how long are you obese or are you fat? He or she retorts telling that I'm not fat, I'm healthy. Right. That's the connotation. And so plumpness is considered as a fortune, and leanness is considered as a sort of cards. So interestingly, we try to reverse this thought through training these informal healthcare workers and imparting this to the villages. And the dividends were really very interestingly forthcoming. There was more, they would imbibe people to do exercise, take more healthy diet and all these, and the results were really very heartening. And I want to emphasize one point here, that the amount of tendency to take to modified diet and exercise schedules were more amongst women than in men. So, they were more amenable to suggestions, to lifestyle modifications than the men folk. So all these learnings had come. I think India is going to have I was just sharing with Professor Sanyal the other day, India is going to have a national non-alcoholic fatty liver disease policy. I strongly feel that we need to have a national or international metabolic health policy rather than one targeted at the liver only, because otherwise we are going to divine injustice to NAFLD as a liver disease. It's really not a only liver disease. We need to look at coronaries, we need to look at other aspects of it, and we need to make people aware of the composite metabolic health. So that's needed at the population level and as a social and sort of cultural modifications, rather than one in which NASH is looked at as only a mathematically the way we look at liver disease to be something like LSM value to be your LSM value is 18, your liver is bad, so you are bad NASH. So I think we need to change, and that's our responsibility, more a holistic way. Yeah.
Dr. Chowdhury, I absolutely agree with you. And it's why in putting together our NASH Council, we reached out to the endocrinology community, the cardiovascular community. My first call was actually to the president of the American Heart Association for her to, bring in, to her to partner, with me on the cardiovascular aspects of this. So you could not be more correct, in my view, and how we're approaching it in developing, a plan for whole person care. I wanted to ask
Donna, I have a wild idea for you before you ask your next question.
Okay.
Somebody's got to be a little crazy on this panel, right? So I'm the crazy one.
Okay.
So over the years, what we've learned is that when we ask people to change over to a more metabolically healthy lifestyle, asking the individual to change where the rest of the family is maintaining the classical non-healthy lifestyle is a recipe for failure. As a community, we all say lifestyle is the anchor and cornerstone for good metabolic health. But whether you're a diabetologist, cardiologist, or a hepatologist, we have done a terrible job of actually making that happen. And we just say, oh, but nobody can do it, so let's just find a pill for this problem, right? And so we have $1 billion pharmaceutical industry. But as academics, I think we have a role to understand why that is so. And so when the whole family changes, then and the key portal to the whole family is the mom. When the mom decides that, this is good for the family, by and large, in most cultures, the family adapts around that. And the best time to capture the mom's attention is soon after they have delivered. So one idea for you is, as you engage with all these groups, is also to bring in our colleagues from OBGYN, because that's, the awareness about fatty liver disease is very low in that. And there's an emerging story that if you have fatty liver disease, you may be more prone to preeclampsia. And so there are a number of groups in the US now actively pursuing that body of work. So there may be a direct impact on your reproductive health as well. And so that's another group that I think we really need to engage with.
Absolutely. And we have reached out to ACOG and other, and I've had some wonderful colleagues in maternal health. And if you couldn't see, the other part of my office is actually a large poster on preterm birth risk reduction from an earlier program I did. So I know Dr. Anna McDeal has made that point about gestational diabetes and gestational health. Leading into partnerships with the pediatrics and NASPGHAN and SPGHAN. It's an absolutely very important point as we build this out as a whole family, whole person health. But let me pick up on the point of Dr. Chowdhury's community health-based program, which I think probably does get to those family issues. Would such a program work in each of your localities, gentlemen?
There was tremendous local enthusiasm and local participation, and I can tell you that, as Professor Sanyal was just mentioning, that in future, and we are planning such an activity, that we will empower the women self-help groups. They are very important social forces within communities in the developing countries. So we will empower women self-help groups for non-communicable diseases as a whole, and train them up and tell them that it's your responsibility to look after the community, and take the message that healthiness, and it depends on hypertension, diabetes, and fatty liver disease, all these as a club together, and they need to be trained, and they need to take the message deep into the communities, instead of this being a very, very cadre-based approach. We need to have a more diffuse social community-based approach of metabolic health.
So Dr. Wong, is that something that you would fund through some of your work and programs?
Funds, we keep on looking for funds from many organizations. I would look forward to any funds that come forward. And I can tell you that we can find you answers to many questions that you are looking for. And I'm telling you, I'm looking for a fund looking for an organization that would fund my women self-help group based approach to non-communicable diseases prevention. And let me tell you that we keep on saying that Indian rural society is changing fast because of craze for a westernized food, motorcycle, and mobile phones. So these three are the enemies. So and the women are the best placed, and as Professor Sanyal was telling, they are the center of all the messages that you can take to the society. So if we can devise a way and we can show that by doing this, we are really getting dividends, that would be great. And it's possible. We strongly believe.
I believe it as well. Dr.
Let's get a reaction from Vincent to these comments.
Yes.
I think for government, when they're going to assess type of program, they would definitely ask for how's the past track record, okay, especially for terms of the performance indicators. So I think there are a few things either. If we want to promote NASH, number one will be whether the penetration rate, okay, how many sectors we get. Second is whether you got a partnership model with the employers. Because I think in Southeast Asians, especially, it's very important that to have the commercial field key health program charter, so that when they sign, when they commit, they can offer, for example, some friendly policies on work. You can imagine if you program on regular exercises, but you don't have much time to do it, it's completely very difficult. Issues. The government, okay, whether it really works well, and any partnership program with different sectors, and especially, what will be the intended outcomes in the coming 3 years. This is what among the public administrators in Asia.
Fantastic. So would I think it's interesting you talk about past track record, because how do we do things? How do we do novel, innovative things if we're always looking at has it worked well in the past? It's something that I've often thought about. So Dr. Noor, would this type of community health worker program work in the diverse communities that you talk about in Canada?
So I think when you look at NAFL, we again, to agree with all the statements, is that it's a very diverse context and population. And you're really looking again at the multidisciplinary team, right? You're looking multidisciplinary, you're looking grassroots, you're looking primary care, you're looking at dissemination of understanding, translation, and knowledge to a wide cohort of persons. And I think I would very welcome the concept of community-based approaches like that, because we do know that that's probably going to be effective. The question is, how do you actually advocate enough that it actually does occur? Mm-hmm. Because, at this stage, if you look at silos of NAFLD, to go to convince payers that this is how you're going to change it, I think it may be a bit challenging. And I think when you're looking at where we can have patient advocacy or advocacy overall, we're looking at different quotes. You're looking at the patient basis, the population basis. Let's look at primary care. Let's look at the multidisciplinary team. Because I think if you can actually affect all these different groups, mm-hmm. and then look at the payers as well, that's probably how we're going to make a nudge in this. And again, not purely looking at the liver perspective, but overall, the metabolic perspective, the outcomes of oncology as well is really going to be key. So looking at those long-term outcomes.
Mm-hmm. Dr. Islam, are either community health worker programs viable in geography, or these types of multidisciplinary fatty liver disease clinics? It seems like there's innovation necessary on both the public health side and the medical, clinical workflow arrangement.
No, I definitely agree that we need a more innovative way, but I just want to touch on the area of the funding. And I think this is one of the main issues that probably we don't deliver our message very probably. So if we take an example, for example, the non-communicable diseases all are receiving 17 times more less funding than disease like HIV, although it causes more than 30 times more deaths than the HIV. Mm-hmm. So this is one of the important points. We have to work on it. Why? And if we look especially from the NSCD, the liver disease are receiving the lowest amount of funding, which clearly is restricting our ability to apply this type of programs. So yes, we need this type of collaborations with other metabolic disease, but also we need to be able to deliver our message very clearly. And I think one of the important things, like what GLI are doing at the moment, is helping to simplify this message, deliver it for different sectors. We probably used to talk to ourselves as academic community, but what you are doing now is very important to simplify the message, strengthen the importance of it, clarifies that fatty liver disease is not only the disease of the liver, it's linked with the risk of cardiovascular disease, diabetes, more than 12 types of cancers. So we need more funding to be able to undertake this type of national actions plans and integration of multiple specialties in the management of our patients.
Thank you so much. It has, occurred to us in the discussion, there's certainly amount of basic science research, but there's also a lot of research that should be done in the types of, dietary interventions that are particularly helpful for people with NASH, the type of exercise and research around the type and intensity and duration of exercise, whether it's more, cardio-based or weightlifting, distance-based exercise, and these areas of research that also need to be funded alongside the drug development if we're going to address this problem fully.
So Donna, can I sort of just to build on that, ask you a question?
Sure.
And that is, when I look at go home every day and turn the TV on and actually talk to my patients, my perception, and you guys are the patients, so you guys tell us. My perception is that when I recommend a healthier lifestyle, the patient perceives that as punishment, that they're being punished for whatever reason. Whereas, everybody else is having fun, they're being punished. We're competing against a commercial agenda that plays out on our television and every media source, from our cell phones, which are blowing up with this, where, it's a lifestyle thing. For example, in every TV show, at the end of a day, they're sitting there with a glass of wine or a whiskey and whatever, or they're eating whatever. So there's a culture, right? So
right.
How do we compete with that? Because if we are constantly trying to give a message that is perceived as a punishment, how are we going to make progress?
Right. And I think that I'll answer that paired with Dr. Chowdhury's issue about, the perceptions of weight in different cultures. I too come from a culture where, being curvier, being having a little more weight on is, deemed beautiful and healthy and prosperous and abundant. And so how do we set people's, accurate expectations of what fun is, what healthy is, what good is, what beautiful is. And I think it's a very complex challenge, but it's one of the reasons why we set a culinary event here for International NASH Day to help people connect, healthy liver healthy eating with a fun social experience, because it does need a makeover. It does need a better marketing plan, and building communities around that and supportive. Because I think there was a study some years ago that your weight was determined by sort of the combination of the weights of your friends and your family members around you. And so we do have to make this conversation about NASH and liver health, globally, a very exciting, fun, social, community-based experience, and reset people's expectations and goals. So
because this brings us back to the original paradigm that the WHO had, which is that health is a positive construct and not just the absence of disease.
Exactly.
Right?
Exactly. Dr. Ron?
The other issue about food is, it has to be placed in cultural context, as you mentioned, because asking someone from Southeast Asia to live on a Mediterranean diet has the same probability of success as asking someone from Italy to live on pho,
Yeah. Never to never have rice, as so many of your hepatology, colleagues would say. I'm like, that I can't go with that message to many communities. So we're going to have to think about, how to phrase that, and how to give, recipes that are, in culture, in context. I know for my father, who had congestive heart failure, I remade a lot of traditional African American Southern recipes in a healthier way with prodigious doses of hot sauce. And as soon as I integrated and told him he could have as much Frank's hot sauce as he wanted, he was sold. He was on the path and with my program. But it had to be anchored in foods and tastes that he found pleasurable and that he was used to and comfortable with. And so how do we adapt that to
so this really requires engagement with the patient community and the people who are doing lifestyle research. Yeah. For too long, the medical community has been paternalistic. We think daddy knows best. We got the answer and we'll come and preach to you, right? But that doesn't work. And particularly chronic non-communicable diseases such as diabetes, cardiovascular disease, and I think, and now NASH, we as a medical community, I don't think have done a good job in trying to promote healthy living. We have an opportunity. Of course, we can sit there and moan about it. There is also an opportunity, I think, to understand why that is so and do something about it. And I think the future is patient-informed and patient-engaged research. And there's a whole science and art around that. So maybe, Donna, I know you're very involved in this concept. Yeah. Maybe you can educate the rest of us around what you're doing in that space.
I look forward to finally coming down to your university and giving that talk that was delayed by the pandemic. And I look forward to visiting all of you, certainly, and working with patients and patient advocates in your localities. I also think that there is a role for medical education, because I don't want to, vilify my physician colleagues here. It wasn't part of your training, correct? It wasn't really a big part of your curriculum and how you were trained in medical school to discuss, specifics about diet and exercise in a way that people could connect with. So is there a role for medical education, revision in how physicians and members of the care team, nurses and PAs and nurses all work with patients on this issue?
So I'm very curious because Ramji and Mohammed both have a patient population which is incredibly diverse.
Right.
How do you advise maybe I can get both of them to answer this question. How do you approach this issue of cultural diversity when you make lifestyle recommendations to your patients?
Mohammed, you want to go first?
Yeah, sure.
Yeah, that's actually so tricky point. But you try, as you pointed out, you try to make some sort of individualized recommendations, which is not like pre-made or recommendations which is fixed for everyone. I fully agree with what you said, Prof, that this is usually don't work. And you have to understand the culture background of your patient. Even within the same culture, we are all different. We have different DNA. We have different way of thinking within the same culture, exactly. So you have to be a bit more closer to your patient and give him the empowerment, give him to lead the process of the management of himself, try to understand what's the obstruction for applying our lifestyle choices. We are all different. Give some time to listen to your patient, try to understand. I think this is probably the way to overcome all the cultural differences. It's just to listen to your patient, take some time.
I think also the context of perception is really important. By the time you get to a specialist, they're not expecting you to say, listen, I need you to exercise and watch your diet. Their expectation is, look, you're going to get a fancy MRI test, you're going to get a pill that you take once a day, and this is going to fix the whole problem. So it's going away from that perception of how you're going to actually positively impact someone's long-term outcomes and perhaps the challenges, because like say it's a punishment, because you're saying, look, you can't drink alcohol, it's start from this much. You've got to exercise, and I use cardiovascular exercise wise, and I do suggest doing some weight for those people who are able to. But you've got a heterogeneous population. Some cannot walk. I can't walk more than 15 minutes a day or 15 minutes. Well, it's 15 minutes. Can you do that? Or 10 minutes? Most people are yes. Well, do it 3 times a day. So it's really trying to work within the patient's constraints. Right. And again, it's not a one size a recipe. Here's a piece of paper, follow it. It's trying to say, what can you do? How can we actually optimize what you're able to do? So I think, again, the multidisciplinary team comes in. The cultural sensitivity, I think, is a key aspect. You're not going to take a patient from Asia and put them into a Western diet in a different sense. Mm-hmm. And then you got to have to really evaluate the socioeconomic aspect, because remember, carbohydrates and fructose is cheap.
Right.
It's really cheap. And that's what a lot of people will have, and sometimes no choice to go to. And so you again have to use those constraints and say, how are you going to optimize that while being culturally sensitive? And then you get thoughts of intermittent fasting, and I think there's too much at this point to discuss that. But, it's again going to those basics and taking away the perception of the pill to move towards the whole liver health or just well-being perspective.
Right. And, to your point, I don't know if it's, angry, but yeah, they are. It's like disappointed. There's this, I've talked to so many patients, there's this profound sense of disappointment. You're like, what? That's all there is, this lifestyle intervention. But when I explain, but it's so powerful. It can actually have these really important outcomes. It can reverse the fibrosis. It can reverse the disease at a certain point if we catch it early enough. And so there does need to be some repositioning of the expectations there.
And I think what you need to have people understand is it's a foundation. It's the foundation of how it should be. It's not the end all and be all. Yes, there will be drugs. We'll be able to modify things. But really, you can't go to that step without, it's like foundation of any building, really. That's where we should be starting. And as you pointed out, to Person's point, at a community level, that's where we need to be at.
Having had a liver transplant, and knee replacements, because of, more than 20 years on prednisone and different medications, I approach exercise as something I get to do. And I'm so grateful for being able to move. And so it's that, perspective that I often share with people who are capable of exercise, but reluctant to do it. I'm like, this is something that you get to do. And I think of all the different things that work in my body today that didn't work, or sometimes still don't work, that, if I'm exercising, it means I'm hydrated. It means I have enough iron in my blood. It means, the blood sugars and kidneys are working right. It means my liver is producing all these things. Like, so many things, miraculous things are happening to allow me to take a walk or be on an exercise bike or lift a weight, that I'm just so grateful to do it. And I hope that more people would view it that way.
May I also share 2 concepts? So are you, sorry, just now for the internet issues. Actually, when we deal with the policymakers up to, for example, the vice minister level or the deputy directors, there are 2 concepts that have been very important in countering the influential effects of culture. Number 1 is what we can find sort of the patient ambassador from the perspective of ethnicities. Because, all different races, they have different uniqueness and they have different preferences. This has been proven very effective. The second is what we call the industry-based ambassador. Because, different occupations, different professional, they will have a different type of lifestyles. Having those people speaking for how they handle the situation when they got liver issues, it become more impactful. Especially when we have collaboration with a hospital network or the health ministry. So this is 2 concepts I think that might be useful. Thank you.
Absolutely. Thank you so much for this. So as we close this out, we've talked about so many very important things, from defining NASH and lean individuals to diagnosing it with simple scalable tools, community-based programs, multidisciplinary clinics, and the importance of medical education, and of course of the voice of the patient and working with their physicians to personalize experience. What, you know, as each of you sort of signs off, what is the one thing out of all these many things that you'd either like to get to a public health official or you know, a policymaker to understand about what we need to do, or to your fellow physicians? Maybe Vincent, I'll start with you, and we'll go to Dr. Ramji, Aslan, Chowdhury, and we'll end with Dr. Sanyal.
Thank you very much, Donna. I think one keyword is the networking. This sounds to be easy, but it's extremely important, because I think quite a number of patient organizations, they did excellent work, just like GLI. But I think if we want to, you know, have a further sustainable impact, it's very important to have networking dialogue, collaboration, just as what I mentioned. If we do have some agendas, for example, when I have some training with Finland and also with the Asian government, as long as you got the networking, I think it's very, very effective in terms of funding, education, or promotion. So networking is my keyword. Thanks, Donna.
Thank you. Dr. Ramji.
I'd say the one word would be awareness. Awareness within the public, within the medical profession, and particularly within payers, that one NAFL's there, lean NAFL is there, the potential outcomes and what impact we could have and how important it is to do now. So awareness.
Dr. Islam?
I want to say finally, thanks for all the effort you are doing and all the GLI. I think that's the key. It's important for increase awareness, deliver the message for outside the hepatology community, increase the networking with the other metabolic diseases. I think this is the key for the next few years.
Okay. Dr. Chowdhury?
Yeah, so I would love to see the government take proactive steps to develop a congenial population level metabolic health awareness and activity programs. While the government and we, the scientific community, keeps on talking about drug development as a panacea, what I strongly believe, having had seen over the last 10 years of significant enthusiasm in NASH drug development, I would love to see a drug appearing tomorrow, but I don't think anybody down under the sun can promise us a remedy tomorrow itself. So for that, it remains prevention, 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 and that's in the lifestyle. So, you know, it's a composite, holistic, instead of a reductionist, specialty-based approach at the community level. We need to develop wellness clinics, and the thought of wellness has to go down to the doorstep, and that's the way to solution. And the government has to step at each of the countries. The government has to take this step. Otherwise, you know, we are going to reel under metabolic ill health in the years to come.
Dr. Sanyal?
Yeah, so without repeating everything, I agree with everything that's been said. So in one word, I think integration. We need to integrate the idea of different organ health under a larger umbrella of metabolic health. The other piece is, I think we have to start young. By the time you take a diseased population, and of course we need to address the diseased population, I'm not denying that, but thinking long term, if we start with our children, and sort of, because the way you think is sort of set by the time you're 10 years old. So there's a very interesting program in India where children were taught about hepatitis B. And there was an incredible uptake of vaccination in the children in the schools where, you know, that education program was there, which has given me the idea that we have to create a similar education program. If the children grow up thinking that living a healthy lifestyle is a very cool thing, that's the right way to do it, then in a couple of generations, we will actually have a healthy society. I think if you ask wrong questions, you'll never get the right answer. That's my final word of wisdom.
I love it. I can't do better than that, than all of you. Thank you so much for all of your insights and expertise and persistence. I encourage everyone who enjoyed this panel to watch the other International NASH Day panels and to follow us on Facebook, Twitter, Instagram, and YouTube. Use the hashtag NASH Day to follow along with the coverage of this and join us for our culinary event this evening, if you can. So thank you. Stay well, stay connected. Bye-bye.